all meet virtually to explore the topic Greater Petaling City-wide Capacity Strengthening of Multidisciplinary Team MDT in Breast Cancer. My name is Dr. Teh, and I am a consultant breast surgeon at University Malaya Medical Center, UMMC, Kuala Lumpur, Malaysia. To date, we have more than 100 participants from various medical centers in Malaysia and crossing several disciplines. Kindly let us know if you have any problem with the audio and the visual. Today's session will be split into two segments: a short introduction by Prof. Aishah and a 15 minutes talk by Professor Benjamin Anderson. We will then have a 40 minutes of MDT discussion with 4 invited panelists and 2 presenters. In case of any technical difficulties, please signal us in the chat. We will try to help you resolve it quickly. We shall now begin. I would like to invite Professor Nur Aishah Muhammad Taib. She is a senior consultant breast surgeon from University Malaya Medical Center, UMMC, Kuala Lumpur, Malaysia. She is currently the head of Cancer Research Institute and has more than 200 publications in peer-reviewed journals. Her area of interest are strongly correlated with patient care and outcomes. She is also the leader of the Management and Quality Technical Committee in the Greater Petaling City Cancer Challenge and City Executive Committee member. City Cancer Challenge Foundation, CCAN, supports cities around the world as they work to improve access to equitable quality cancer care. Without further ado, I welcome Professor Nur Aishah.
Thank you, Dr. Teh, and welcome, Professor Ben, for taking your time to be here. So why are we here today? So I think it will be very apt to put in some introduction about the City Cancer Greater Petaling. And really why we are here today is that cancer is the second principal cause of not only premature death, but also death in Malaysia. So this project is being managed by the City Cancer Challenge group, for which I could just give a bit of summary. We were very lucky to be able to participate in the City Cancer Challenge, which is a global event that occurs in now about 11 countries or 11 cities in the world. So at the moment, we are still in the process of needs assessment in the city, in the Greater Petaling. So we are supported by the City Cancer Technical Corporation. And really, this City Cancer Foundation, it was launched back in 2017, and now is a standalone Swiss foundation based in Geneva. So as mentioned, there are about 11 cities around the world that has taken upon themselves to go through the 2-year program, which is really to learn, empower, and grow in terms of improving the quality of care. So as I mentioned, Greater Petaling City Cancer Challenge is now still in the needs assessment process. However, we have been funded by the Islamic Development Bank and the International Agency, Atomic Energy Agency, that has actually funded an MDT project in the Greater Petaling. Hence, we have started this project prematurely before we could be able to complete the other steps in the framework of City Cancer Challenge. So this grant was launched in 2020, and we won the grant to run this project, which is the building capacity in Greater Petaling in terms of the breast cancer MDT management. So the real aim is to strengthen the multidisciplinary team care and standardization of care of breast cancer in Greater Petaling by this year, November 2022. And the grant duration has ended in November 2022, and we have now taken over by a sustainable partner, which is the Academy of Medicine of Malaysia. And this project will carry on for a year till the end of December 2023. Let me share with you our project team members who we have people from Ministry of Health, Dr. Anita Bagawi, as well as Dr. Izuna Mudla, who are co-leads in this project. And we have our radiologist, Dr. Vijay Lakshmi, Dr. Muhammad Rafi, who is a pathologist, Dr. Patricia Gomez, consultant prestigious in the private sector, Dr. Vaishnavi, a consultant oncologist in MOH, Professor Lam Chilung, as well as our nurse, Matron Nur Nadia. So it's a multidisciplinary group of people who is here to help move the theory of change, where the development of multidisciplinary teams with resource-appropriate guidelines and treatment protocols are expected to ensure the quality and standard of cancer care across the city and, of course, beyond. As mentioned by Dr. Teh just now, I think we have registrants even as far as our Borneo Island states, Sabah and Sarawak. So, really, what has come about from this project are three main outputs, which the first one is a document to help disseminate best practices of implementing MDT for breast cancer. The second one is the capacity development of MDTs with the combination of the multidisciplinary care management course that was run by the ESCO as well as CCAN in September this year. And now we are actually starting upon the capacity development on MDT clinical case discussions and management of breast cancer patients in 12 hospitals with specialists around the city. So the MCMC ESCO took place on the 17th and 19th September this year, and we had 6 hub hospitals with city technical experts from all the specialties who participated in this course in order to take on the project for the next year. So the document that is currently awaiting Ministry of Health endorsement is a document that helps to provide information on hospitals that would like to start on best practices in MDTs. And this was led by developed by the project team as well as CT expert. And we have been mentored by our CCAN Technical Cooperation team members, as well as Professor Joseph Maria Boras Andres from Spain. And we also have had external review of this document from Breast Surgery International. So the document has a very good stepwise implementation framework for anyone who wants to start an MDT in their hospital. So we hope that this document will be ready for you in 2023. So you can use this document to help us start on the MDTs in your hospitals. We also have put in some KPIs as well as a process and outcome indicators that you may be able to use to measure quality in your hospitals. So with that, I think where we are today is really to create a form of network between hub hospitals, which are hospitals that have all the disciplines who can support our single specialist hospitals around the city as well as around the countries. So we have quite a number of hospital and health institutions from Ministry of Health. We have about 10 in our group now, and from the Ministry of Higher Education hospitals, as well as the private sector hospitals that are actually collaborating right now to complete the needs assessment of City Cancer Challenge and to participate in all our activities. So with that, I thank you, Dr. Teh. I shall pass this back to you. Thank you very much.
Thank you, Prof. Aishah. A lot of effort has been put in thus far to reach this level. Hopefully, we could take this initiative and benefit from from all this effort that Prof. Aishah and team has put in. Next up, I would like to welcome Professor Benjamin Anderson to share with us on the WHO Global Breast Cancer Initiative. Professor Ben is a professor of surgery and global health medicine at the University of Washington. He was the president of the American Society of Breast Disease from year 2005 to year 2007. He's also the vice chair for the National Comprehensive Cancer Network NCCN Breast Panel. On top of that, he is also the WHO medical officer leading the Global Breast Cancer Initiative, launched in March 2021. Welcome, Professor Anderson.
Thank you very much for that kind introduction. And what I'd like to do is walk you through the Global Breast Cancer Initiative, its general approach with a specific focus, as you had requested, on breast cancer early detection and diagnosis. So let's first consider the overall needs. Breast cancer is now the most common cancer globally. It is the most likely reason a woman will die from cancer. There are more disability-adjusted life years lost to breast cancer than any other malignancy. The majority of breast cancer cases and deaths occur in low and middle income countries today, and that problem is worsening. By 2040, 60% of the projected 3 million new cases and 70% of the projected 1 million new deaths will be in low and middle income countries. There is this very broad 5-year survival range, greater than 90% in North America and Western Europe, but 66% in India and 40% in South Africa. So it's a clear issue of healthcare disparities, but it's also a statement of opportunity because it shows that we actually are able to improve breast cancer outcomes. Breast cancer mortality in North America and Western Europe has dropped by 40% age adjusted since 1990. The question is, how do we translate that into limited resource settings? If we think specifically of Africa, where the age distribution is younger because the population is younger, half of the breast cancer deaths occur in women under the age of 50. And for every 100 of those deaths, there are 210 children who become maternal orphans. So this is not just a healthcare issue, not just a social issue or economic issue. It is a generational issue. And that's why we have to be thinking this through today. When I started with WHO in 2020, we first surveyed our 6 regional offices and asked for guidance on what are the nature of the problems. And what they told us was that governments in general have been getting into the idea of non-communicable diseases, but they're not quite past the tipping point of moving beyond infectious disease. We recognize that civil society plays this critical role, both in patient education, but also driving political will, which is necessary for making improvements in outcome. From a health system standpoint, many countries have these parallel delivery systems. We have the public system and the private system. I think that this is true in your region as well. And so that tends to create disunified approaches. And within countries, we have underserved communities. This is definitely true in the US, where within this high-income country, we have these regions that are underserved. And so countries are not homogeneous, and we have to think that through. Access is difficult, especially in rural areas, and it's difficult to advocate for change. Certainly the medical community is not particularly effective. The civil society, I think, is a better driver in terms of getting governments to change their approaches. We have information system issues, that how to convey this. We have financial toxicity and constraints in terms of payment. We'll talk about that a little later. And therefore, we need to think of partnership. Advocacy groups for education. This is one of the reasons that WHO works with CCAN. Professional organizations that help standardize care. That's how oncology works. And then strategic partners to help us fund these issues going forward. So it's a complex set of questions that we have to think it through. But ultimately, improving outcome is based on the biology of the disease. We can have political arguments, but cancer is not political. And so how does this work? Ideally, we would think of primary prevention. And there are many risk factors we know that are associated with breast cancer outcome. So lactation is better, being physically fit, weight control, avoiding alcohol. We now know there actually is no safe dose of alcohol from a cancer perspective. Avoiding hormones, avoiding excessive exposure to radiation. But if you said, if we got everybody to do all the things they were supposed to do, how much would that improve breast cancer outcomes? Maybe 20% of cancers are attributable to risk factors. 80% still require healthcare systems that address that early detection, diagnosis, and treatment. Alcohol is probably the single most modifiable risk factor. It is associated with 7 different types of cancer, 750,000 new cancer cases every year, 170,000 new breast cancer, 170,000 new cancers among women, of which the majority are breast cancers. And so 5% alcohol association, which is not a small number, but again, not as big as we would like. So we're all familiar then, if from an early detection standpoint, with the data about mammographic screening. And I think we have very good evidence that for women ages 45 to 69, mammographic screening can improve breast cancer mortality by about 20%. What we've done a really lousy job is explaining what that means, because that's much bigger than, in fact, buying a bunch of mammography equipment. When IARC looked at the data, they said, we think there's adequate data to recommend mammography, at least for women ages 50 to 74, ages 45, adequate data. But in fact, that also gets you into the overnight diagnosis discussion that we're not going to go into in length today. But is it affordable? In high-income country environments, it is, but actually it is not at all clear that mammographic screening is affordable. We'll talk about this a little bit later in the course, but it's not the first step, and that's the part that we really have not explained well. Actually, what WHO focuses on is early diagnosis. Early diagnosis means figuring out how do we get the women to come in the door with early stage disease. Mammography is one method for doing this, but what about the women under age 45? What about women between mammograms? And what about systems that cannot afford mammographic screening? Well, if you screen 1,000 women, 150 will need a diagnostic workup, and that may find 7 cancers. Those will be standard numbers. That's a big investment. Whereas if we can find women and help get them in when they have early lumps, early symptoms, that's a prerequisite. If you can't manage the cancers that you can feel or see from across the room, you certainly are not prepared for handling the cancers that you can only see on the screen. But the question had been, is waiting for symptoms too late? Is that going to be a problem? We now have data about this from India that says, no, that actually is not the case. And you can improve outcomes with late stage disease through clinical detection. Clinical breast examination has been used as a screening test in 2 different trials, the Trivandrum trial and the Mumbai trial. And the Mumbai trial showed us that actually not only were they successful in downstaging cancers, in getting stage shifting for early stage disease, they found mortality benefit in women over the age of 50, which is actually very similar to mammographic screening. This is not an argument against mammographic screening. That's not where I'm going, because I think we have very good evidence about mammographic screening. What this is an argument for is that's not where you start. Where you start is clinical detection, and those systems need to be in place. So that leads us to the initiative. How do we actually address this overall? The objective of the Global Breast Cancer Initiative is to reduce breast cancer mortality by 2.5% per year, which would save 2.5 million lives over a 20-year period. There are 3 pillars for this initiative. The first is health promotion for early detection. The second is timely breast diagnostics. And the third is comprehensive breast cancer management. And this is actually following the patient pathway. Conceptually, we're marrying 2 different approaches. One is the public health sciences approach, where we think of the population as a group and ask, what do we do at that population level? But we're marrying this with clinical thinking, which is how do we actually get patients through the system one at a time? Here you see the mortality curves for breast cancer in 10 countries that have successfully reduced breast cancer mortality between 1990 and the present time. That has been a 40% drop in breast cancer mortality in those countries. That is between 2 and 4% per year. So when we talk about a 2.5% mortality drop in breast cancer, that's not an artificial or fake number. That's a real number that was actually achieved in these countries using tools that today we would consider standard. The question becomes, how do you translate that to limited resource settings where we have not yet seen those benefits? And the thesis is it's through clinical management, because that's what really worked in the 1990s. That first interval where we get the patient in the door, the second interval where we make a diagnosis, that's the question you asked me to address today, and the third interval is the treatment, the management. So in those first 2 intervals, that first is health promotion for early detection. This is getting early stage disease. It's an educational approach. You need to educate the public about what they need to know. What is breast cancer? What are the symptoms of early stage disease? And why in the world would I come in to have evaluation for this? And we want to link that public education to existing initiatives. So if cervical cancer screening is taking place for women ages 30 to 49, we want to have education for the same time to help them understand what is early detection and why would I participate. But you also need to educate the providers. The primary care providers need to know about breast cancer, otherwise they may not recognize it in its early forms. And so having educational materials for them, as well as educational materials for how do you do a diagnostic workup, that if someone comes in with lump, what do I do? How do I do this? If that is not set up, you cannot anticipate improvements in outcome. The overall target is for 60% of the invasive cancers to be stage 1 or 2 at diagnosis. And if you ask, where did that data come from? We published a study last year looking at all countries for what characterized systems that make them able to improve an outcome. 35 of them had adequate data to look at stage at diagnosis and mortality. 20 achieved that improvement in outcome, 15 did not. And what was the difference? 60%. Every country that has improved outcome in breast cancer mortality has had at least 60% of invasive cancer being stage 1 or 2. Conversely, we know of no country that has achieved reduced breast cancer mortality without crossing that line. So rather than arguing about mammography versus clinical exam versus the test, instead of arguing about the test, we're providing a benchmark that helps countries know where is it that you need to be and how far away are we if late stage disease is our problem. That second interval is timely diagnostics. How do you prove that it's cancer in a reasonable period of time? These are basic tools: ultrasound in Rwanda, a pathology lab in Ghana, and the use of leapfrog technology. Immunohistochemistry is essential for knowing tumor markers, but it's hard to do. So what about using PCR? What about leapfrog technology? How can we approach this? This is an area in which we're very interested. But the idea of patient navigation, how do you get them through the system? Not just what do I have in my hospital, but where's the patient and how do they get to me is really important thinking. Our overall target is to get a diagnosis within 2 months, 60 days. The reason that that is the cutoff is because at 3 months, that's when we start to see decrements in breast cancer survival. And so that's an evidence-based approach. In fact, Brazil in 2012 passed a law saying patients need to start treatment after diagnosis within 2 months. And this is an example of linking policymaking, which is what WHO is supposed to do. We're supposed to advise governments about what policies to have. It's an example of a linkage between those policies and actually improvement in outcome. The third pillar is comprehensive management through multidisciplinary care. And we need to follow patients after that to find out, do they have the resources they need once they re-enter the community? The goal of this is for 80% of patients to get through their care without abandonment. This is a huge topic because if patients start treatment without finishing it, then you cannot anticipate them having improvements in outcome. And that I will show you data about that in a minute. But when we looked at health systems characteristics, here's a stark problem. Of 141 countries, when we looked at what factors were associated with improved breast cancer mortality, one was degree of universal health coverage, and the other was access, number of public cancer centers per 10,000 cancer patients. If you don't have a way to pay for the care, and if they don't have access for making the improvements in outcome, you cannot anticipate an improvement in outcome. And that it doesn't make paying for cancer easy, but it does make it necessary. When we look in Africa and we look at these 3 indicators, improved treatment, downstaging of disease, and increasing access, those blue bars are 3-year survival in sub-Saharan African countries as measured in this decade. The colored bars show how much improvement you could have if you just addressed that access, the downstaging of disease, and the improved treatment as measured by avoiding abandonment. In Africa, what you can see is the data showing at least 50% of patients don't get all of the treatment that was prescribed. That's a big issue and likely an issue in countries in your region as well. Finally, I just want to talk about the approach that WHO takes, which is we think about the service delivery. We are developing a monitoring and evaluation framework that, based upon the WHO building blocks, looks at how do we measure these outcomes. This is important because if I don't have adequate time to diagnosis, what are the contributing factors? You have to be able to dissect out with this fishbone analysis to say, What might be the problem with service delivery or information or navigation? We want to develop in a system so that we can properly advise countries on what it is that we're able to go forward. And we want to be able to map it in ways that are useful. This is the map of Namibia, and what it shows is differences in those 3 pillars by skin color: white, mixed race, and black. And what you can see geographically is where the gaps are. Where is late stage diagnosis taking place? And how is time to diagnosis in these different regions, so that the governments can properly target their interventions. Just doing something in general is not as good as sorting out where those gaps take place. We can project outcomes going forward. We can project stage distribution by intervening with early detection strategies. What this graph shows is that actually the difference between mammographic screening and clinical detection is not as big as one might think. Again, arguing for clinical detection being this first step. We can see major differences in survival, improved survival, reduced mortality based upon these interventions. We can project this for countries, and we can tell them about the costs that are associated, because the Minister of Finance needs to know what it is to do going forward. In summary, we now have UN mandates to move forward with non-communicable diseases. We see breast cancer as an index disease, because if you can address breast cancer, there are a lot of cancers that you can address. We see early diagnosis as this essential element, whether you're doing mammographic screening or not. Doing early diagnosis, finding patients when the stage disease is still early is necessary. But don't forget that early detection only works when it's followed by treatment without abandonment. As such, we are proposing that the Global Breast Cancer Initiative is a catalyst for change to help healthcare for women throughout their life continuum. Thank you very much for your attention for this high-speed talk through the Global Breast Cancer Initiative. Back to you.
Thank you, Professor Ben Anderson. It is clear through what you mentioned that education, timeliness in both diagnosis and treatment could affect our patient's outcome. Comprehensive management through MDT and also patient navigation system is equally important to maintain the outcome. I would like to now move on to our MDT today. We will invite a few persons to this session. Dr. Teo Ying is a breast surgeon from UMMC. She will be moderating this session. I will also like to invite Dr. C. Boon Kiong, who is a general surgeon, and Dr. Choong Kah Lai, who is a radiologist from Shah Alam Hospital. And our panelists for today will be, we will have 4 panelists from UMMC Kuala Lumpur, Malaysia. We would like to show them how the MDT is done in UMMC. I would like to invite now Prof. Aishah, our breast surgeon, Professor Kartini Rahmat, radiologist, Dr. Chiew, our pathologist, and Dr. Fadhlina Abdul Satar, our oncologist. I'll hand over this session to you, Lee.
All right, thank you very much, Dr. Teh. So thanks once again to the organizer, especially Prof. Aishah, for inviting me as one of the moderator. And as what Dr. Teh has explained, we have a group of very experienced specialists in their own field, especially in dealing with our KPI to the pillar 2 in our GBCI as presented by Prof. Anderson earlier. So before we start, actually this is part of our City Cancer Challenge. Maybe it's good to actually give an overall view, maybe to Prof. Anderson as well, regarding our health system here. So as mentioned before by Prof. Aishah, in Malaysia, we do have health institutions from both the private, the government sector, as well as a few university hospitals around under the Ministry of Higher Education. So the problem is we do a lot of massive screening, right? So we detected a lot of patients, but what about the diagnosis that we aim to achieve within that 60 days? So as part of this program, we would like to actually demonstrate how our MDT is being run. And today, our surgeon, who is Dr. Boon Kiong, Stephen, from Shah Alam Hospital, which is one of our spoke hospital, will actually introduce to us a case. It's a real case. and then we will just discuss as we go along. So just a brief introduction about Hospital Shah Alam. It is one of our spoke hospital under the care of, Hospital Klang, as well as part of it under Putrajaya and UMMC in Kuala Lumpur. And the service has started in 2015, and they catered about 30 beds for female patients, as well as running a general surgical outpatient department. So Dr. Stephen is also accompanied by Dr. Choong, who is the radiologist. I would like to just briefly introduce Dr. Choong first, and both of them will be actually presenting the case today. So Dr. Choong completed her postgraduate studies in a Masters of Radiology with a fellowship in Royal College of Radiologists in 2015, and currently working as a clinical radiologist in Hospital Shah Alam since 2017. So as we have the panelists, I will just briefly go through a very quick summary. So first, we have our breast surgeon, Professor Nur Aishah binti Mohd Taib. So she is none other than our lead person in the City Cancer Challenge in the Greater Petaling, and also she has special interest in quality improvement and genetic screening in breast cancer, and currently the director in the Cancer Research Institute. Next up, we do have a representative from the radiology department, who is Professor Dr. Kartini binti Rahmat. And she has a very special interest, and she is the person to go to if we have any dilemma regarding our breast imaging. So she's the expert in the MRIs and all sort of imagings regarding to breast cancer. And next up, we do have Dr. Chiew, who is our anatomy pathologist, currently with us in UMMC, and started off her, completed her treatment, her training in 2018, and has been working actively in our center now. And last but not least is Dr. Noor Fadhlina, or Dr. Nina binti Abdul Satar, who is our senior oncologist also in and she has special interest in breast cancer and involved in many industrial-based trials. So may I have Dr. Stephen to share the slides now, and then let's go through, and please keep your questions to the last 50 minutes of this session, and we hope to probably complete this MBT in half an hour's time. Thank you.
Thank you for the kind introduction. So can everyone see my slide?
Yes, Stephen. Yes.
Okay. So this is a case presentation. The patient was treated in our hospital in Shah Alam. So this patient was actually presented to us. The patient is a 1 SBA with age of 55 years old. So she was actually detected by the Breast Cancer Welfare Association during the screening public campaign in PJ on 21st of August this year. So subsequently was referred for the LPPKN subsidized mammogram screening program. And the patient actually went to the LPPKN clinic, no Sejahtera, did a mammogram, and subsequently was referred to our hospital. So from the history-wise, the patient claims that there is a right breast swelling this year. She's unsure about the month and duration. Claims that the swelling is increasing slightly, occasionally associated with discomfort, but there's no constitutional symptoms, no bony pain, no shortness of breath, and there's no stigmata of liver failure. She's a nulliparous, and actually from the gynecological history-wise is negative. There's no other hormonal usage or any OCP usage. Social history-wise, she's separated from the husband and she lives alone, and she's under our B40 group. For the family history, her father was diagnosed with colon carcinoma, which he passed away. The patient unsure of the age of the father that time. So during our examination in our clinics, we noted that there is a right breast lump over the right upper outer quadrant, which is 3 × 3 centimeter, mobile, and there's no skin changes. It's firm, non-tender on palpation, and there's no nipple changes. There's no axillary lymph nodes or supraclavicular or cervical lymph nodes palpable. There's no hepatomegaly or pleural effusion at the time of examination. So clinically, the patient is T2 and 0 MMX. So at the point when we saw the patient, we did a freehand biopsy for the patient, and subsequently we requested the further imaging for this patient due to the findings in the mammogram. So For the mammogram, I'll pass over to Dr. Choong, our radiologist in Shah Alam.
All right, perhaps before we step on to the next step of our assessment, maybe we get Prof. Aishah to comment slightly on the referral pathway that this patient had, and is there any comments on the plans? I mean, we are here to learn, so whether you have any differences in the opinion and how you manage.
Yeah, I think this patient, she was detected through a public health campaign being conducted by the Breast Cancer Welfare Association. So they do have a lot of these public campaigns. They have a large pink van and they do clinical breast examination, and they work very closely with our Ministry of Women's unit that actually provides subsidized mammogram vouchers that can be done in the private sector. So we have a project at the moment in the community called Rebung, Reducing Barriers in Early Diagnosis among the Urban B40 group. So we work with them to create some public campaigns together. And through them, they have discovered this patient, and hence, despite she being B40, she really has problems with transport and everything. So what has happened is that we communicated very closely with our hospital Shah Alam colleagues, Dr. C, as well as Dr. Choong, because we have now created a bit of a network, because the pilot is actually in Taman Medan in Petaling Jaya, where we actually have a diagnostic center nearby. Because whatever said and done, I think Professor Ben Anderson mentioned that a successful story is when you have universal health coverage. Because this lady, she is from the bottom 40%. She's unable to afford, she has no social support. So the project that we're doing provides some degree of support in terms of research assistance, helping them to navigate the system. So maybe just to highlight that she's 55 with a query problem. When she did the screening, the nurses felt a very vague lump and they were unsure. So she went through the normal process of getting the LPPKN mammogram done in a private hospital. And only after that, the mammogram showed the abnormality. And then we navigated her to the closest diagnostic hospital that can provide UHC for B40, which is Hospital Shah Alam. So that's probably the initial part of this patient. So, and then I think Dr. C then went on to complete the triple assessment, right? So you did some risk assessment of the patient. You talked about the family history, whether the patient is on hormones. And as what Professor Ben showed earlier, there's not much risk factors that you can actually look at, except that she's female and she's older. So whatever it is, when a patient like this turns up, even with a vague lump, it's no longer screening, it's already what we call diagnostic, because there is a clinical finding. And I guess the process is the same. So maybe Dr. C, you want to complete your talk about the triple assessment, what was done to the patient, and maybe then Prof. Kartini could actually comment on the findings also.
Yeah, so can we share the subsequent slides on the mammogram? All right, for this one, would you pass over to Dr. Choong? Stephen?
Yes,
right.
Dr. Choong.
Thank you, Dr. Teo, Dr. C and Prof. So this is mammogram images of the right breast, RCC and right MLO view. There is an ill-defined, speculated, irregular mass seen at the upper outer quadrant of the right breast. There is associated clustered microcalcifications within the mass. There are enlarged right axillary lymph nodes seen, which show loss of fatty hilum and with irregular cortical, with thickened cortex. All these features are suggestive of malignant breast lesion. There is another smaller nodular lesion seen at the left lower inner quadrant of the right breast, or of the right breast. There are some foci of calcification within. So moving on to the left mammogram. So the left mammogram in 2 views are fairly clear. So and moving on. So in conclusion, this is a magnified, the same lesion but magnified. We can clearly appreciate the speculated margin of this mass with the clustered microcalcification seen within. These are features of malignant breast lesion. Moving on. So in summary, these mammogram findings show the pathological findings of Piret's category 5 in the right breast. And in the report, it was mentioned the speculated lesion with microcalcification is highly suspicious of malignancy and was given a Piret's category 5. Okay. Moving on. Moving on to the next. Yeah, just a brief mention on the Piret's category for mammogram reports for the breast. The Piret's category can range, is numbered 1, 2, 3, 4, and 5, the main categories. Piret's 1 refer to negative mammogram findings for malignancy. Piret's 2 refers to mammographically benign lesions, such as fibroadenoma, cysts, scars, vascular calcifications. For this type of patient, Piret's 2, usually no additional actions required. For Piret's 3, the lesion is probably benign. They might include non-calcified nodules, dilated ducts, architectural distortion, that at the point of scan, we are unsure of the exact nature. So the management for this patient would be a short-term interval follow-up, usually either ultrasound or mammo. Piret's 4 would be suspicious lesion. It can be from low, moderate to high suspicion. This lesion, they can be asymmetrical in appearance, localized, or they show evolving changes during the follow-up scans. They might have some irregular contours. So biopsy is definitely recommended for patients with Piret's 4. And lastly, Piret's 5, as per our patient, the findings are highly suggestive of breast malignancy. So they usually include lesion with clustered suspicious microcalcifications, or they can be associated with architectural distortion, speculated irregular contours, as in our patient, as in this case. So this patient would definitely benefit from a referral to the surgical clinic for biopsy and then for further management. There are also Piret's 0 and Piret's 6. So for Piret's 0, usually it means that the imaging needs to be inadequate and need to be compared with any previous imaging, or this patient needs for a complementary ultrasound, for example. And Piret's 6 usually refers to those who is confirmed breast malignancy. Moving on.
Okay,
Patient,
I think we step on to the next mode of imaging. So I think I just want to pose the question to Dr. Choong. I think you mentioned about ultrasound as a complementary. So based on that images that you saw in the mammogram, would you consider doing the ultrasound in the same setting, or what would be your approach?
Like Prof. Aishah mentioned earlier, depends on where the patient has the first, mammogram. Some of the patient had their mammogram, like this patient, done in private. So I'm not too familiar with the practice there, but as I'm from the government side, but if I'm not mistaken, what that side, they usually will proceed with the mammogram, and then the report will be reviewed by the requesting team. Then if a mammogram is done and inconclusive or the breast is dense, unable to rule out mass, usually the mammogram report will be BIRAT 0, and the patient would need to have to arrange ultrasound. Just to, as this is especially for those patients with dense breast that we cannot clear the patient of malignancy based on mammogram alone. But on the other hand, if the patient has the first mammogram done in, say, like a secondary or tertiary government hospital, they have the facility to actually proceed with the ultrasound in the same setting. So then the overall radiological assessment will be completed within the same setting.
Okay, so I would like to pose this question to Prof. Any opinion from your side, Prof. Kartini?
Thank you, Dr. Ling and Dr. Choong for the case presentation. I would like to address the management of this patient. I think I echo what Prof. Aishah had mentioned earlier. This was clearly a diagnostic case, no longer a screening case because of the lump that she had and some other symptoms. And the fact that she had a mammogram, I think in August, but it was referred to the surgeon for the lump with a mammogram, but without an ultrasound. Maybe I should not pose this to the person who was who had done the biopsy, but more of the person who had reported the mammogram. Because I see in the report that they mentioned that an ultrasound is required. First of all, you know clearly that there were very malignant features on the mammogram, the speculated mass, very high density, right upper outer quadrant, but there was also another indeterminate lesion in the lower inner quadrant, which was separate from the index lesion in the right upper outer quadrant, and there were lymph nodes there. And the fact that this is a mammogram, usually we mention the BIRATS density. The BIRATS density is not so dense. I think it was a lower. Probably we could give a BIRATS density B, so we could clearly see the margin of the lesions, the calcifications. And usually when we see a lesion, we would like to know the dimension. And it's quite difficult to know the dimension or the size of this mass on the mammogram because of the poorly defined margins. The ultrasound should have been performed to further assess this mass. And we should also investigate whether this is a unifocal mass or multifocal matrocentricity, since we clearly think this is going to be a carcinoma. And because of the presence of the lymph nodes, it's difficult to identify or assess lymph nodes on mammogram, despite the fact that we can say that there are multiple nodes there, but there are also multiple nodes on the contralateral breast. And ultrasound would clearly be optimal to assess this. We could see the size, we could see the cortical thickness, we could see the loss of fatty hilum. And in this case, then either we do the ultrasound after the biopsy when we get the cancer diagnosis, or at least at one point of time before we actually do the CT scan, which was performed later on. Although CT scan can actually say matrocentricity, but I think the ultrasound would be best, because if this patient had to be given a neoadjuvant therapy for whatever reason, then at least you have a modality that would be reliable in along the management.
All right, so you pointed out that it's quite important, and I do agree that ultrasound should come hand in hand in this case. But what are the obstacles that you normally face? I mean, both Dr. Choong and Prof. Kat, catching up with all these so-called KPI of 60 days to the treatment time. So is there any problem that we are facing in our own institution as well as our scope hospitals regarding the timely diagnosis?
I think that one Dr. Choong should answer. That's
so what in your practice then?
Okay, mine. Okay. I belong to a tertiary center. It's a teaching hospital. It's a there's tertiary care. We have all the, I think I have to admit that we have the complete multidisciplinary team. We have the primary physicians, we have the breast surgeons, we have the radiologists, we have the oncologists, and of course the imaging is integral part of the management. So we have a one-stop center where for diagnostic cases, because they are important and urgent, we usually have a one-stop clinic where they usually are attended to once a week at our urgent breast assessment clinic. They usually have the mammogram if they have not had ultrasound, and usually if it's a biopsy, freehand biopsy is usually performed the same day. That's why we need the ultrasound, because usually the surgeons would love to see the ultrasound images, including the axillary assessment. But if we do have the image guided biopsy via stereotactic or ultrasound, we usually perform our KPI is usually within 2 weeks or 14 days. Because the pathology diagnosis is usually within a week. So we try to get the diagnosis and the treatment within like the WHO recommendation of 60 days.
Yeah, I think we have the luxury of obtaining quite an urgent slots for some of our BIRATs, 4 BIRATs, 5 patients in our clinic. But I'm sure that this luxury doesn't apply to everyone across the nation. So, I mean, we have to find what is the best way to tackle into this. But I think the important thing is that there'll be a question when if somebody saw this lesion which is palpable, and would you, I mean, this question can also be answered by Prof. Aishah, whether should we proceed with a freehand core needle biopsy, or shall we just wait for the ultrasound biopsy and then we just take all the biopsy of non-palpable lesion and palpable lesion at the same second? What's your comment? And whether over to you first.
See, the thing about organizing the timeliness is a big challenge for everyone. I think in PPUM, we've always been a very busy hospital also. I mean, in the last 20-30 years, because we had Professor Yip since then. So what we really did maybe about 8 years ago was to see how we can actually free up the days which we have a clinic and the mammogram services at the same time. So Wednesday is our breast clinic, and we had a screening list, a mammogram screening list on Wednesday also, which we freed up about 15 to 20 people in that list for the urgent cases. So that when people came into the clinic for the first time and they needed an ultrasound before the biopsy, we could really get those ultrasound done on the same day. And some women just come with the breast lump and we do the triple assessment, mammogram, ultrasound on the same day. But it was done like 8 years ago. And before that, we also had problems because we had a full screening list on our breast clinic day, and we couldn't really fit our patients into that busy list. So just by changing a little bit of our timing, you know, and how we schedule our patients, we free up some slots for these urgent cases. So I think all of us have heard so many times, right, about is this early diagnosis or screening? And should we do ultrasound before the biopsy? So there's a study done by my PhD student in 6 public hospitals. One of the most independent factors to a delay in diagnosis is repeated biopsies. So I think the surgeon needs to assess the breast lump to see and to look at the ultrasound, because sometimes your ultrasound may find a small lesion, but you have this large palpable mass. So in those cases, we shouldn't be doing freehand biopsies. And if the surgeons are equipped with an ultrasound in the clinic, you can actually do ultrasound guided biopsy for the large lesions. So Kartini, we also know their list is very, we see a lot of image guided biopsy. So what we do is for lumps that are larger that we can attempt in our clinic using the ultrasound, we would do it. But for the small, tiny ones, 1 centimeter and below, that we leave it to our very eminent radiologist to sort out. So I think it's important that the surgeon does the clinical assessment and has the ultrasound to make that decision. Are you going to do freehand or are you going to do image guided? I hope that answers some of the queries.
Okay. And also, I think it's quite important in a surgeon's perspective in what kind of surgery we're going to offer later on. Let's say patient goes for neoadjuvant, whether it's a mastectomy or a BCS. Okay, let's move on. In the interest of time, I think we have a few more slides to go. Maybe Stephen, you want to continue with the next few slides?
Okay. So subsequently, after we saw the patients, in view, the HPE came back as actually proceeded with our freehand biopsy, and we got the HPE as ER, PR negative, and HER2 positive. So hence, we have to refer the patient for the neoadjuvant chemotherapy. So before we can able to proceed with our neoadjuvant chemotherapy, we actually have to know about the lymph nodes. Is it actually a malignant lymph node? Is there any lymphovascular invasion? And as requirement from the IKN, they need a CT scan. Hence, we proceed with the CT scan for this patient. So again, I pass over to Dr. Chun about these CT scan images. Dr. Chong.
Oh, sorry, the mic. Thank you. CT scan thorax abdominopelvis was done on the 8th of November. The summary of findings will be it confirmed the right breast lesion, which is HPV proven carcinoma with bilateral axillary lymph nodes, more on the right side, and bilateral nodularities suggestive of metastasis. A tiny liver cyst is seen, 0.3 cm, as well as other findings of gallstones and uterine fibroid. So moving on, we will be moving on. So the first image shows the speculated irregular enhancing right breast lesion. The second image showed bilateral lymph nodes, more with loss of fatty hilum, more on the right side, right axilla. And moving on to the next. So there are some nodularities seen at basal segment of the right and left lower lobes. So there's no pneumothorax, no pleural effusion. Moving on will be the image on the left pleural. There are also similar looking pleural nodularity. The rest of the lung parenchyma actually clear bilaterally. And moving on, the tiny cyst of 0.3 cm is seen at the segment 8 of the liver. It is actually quite small and not specific, but we cannot totally rule out metastasis in the presence of a primary malignancy. Thank you.
Okay, thank you very much. Maybe I think, Stephen, would you like to show the next slides on the HPE? Yep. Okay, so I think, Stephen, earlier you mentioned that you planned this patient for neoadjuvant chemotherapy, is that right? And I'm sure that you base this on the HPE.
Yes.
All
so
right.
we saw the patient actually is HER2 enriched. I think that we think that the neoadjuvant chemotherapy will actually benefit the patient without knowing the CT scan that the patient is having later on. So once the CT scan is there, we actually have to revise our clinical diagnosis for the patient, and subsequently we have to call back the IKN to inform them about the CT scan finding.
Yeah, I think the other reason is also because we have repetitively mentioned that the lymph nodes are actually positive, and now it has involved the contralateral as well. We are not very sure yet, right? Okay, so maybe for this slide, I would like to invite Dr. Chiew to comment on the HPE is reported, and what do you think of the additional information that you would like to offer in this patient?
I think because just based on this report, I don't get a chance to look at the slide. But routinely in the place where I practice in, it belongs to a tertiary hospital, university hospital. In a biopsy, routinely we practice to offer a grading, Boon and Richardson grading for the biopsy if it's a breast cancer, whether it's grade 1, grade 2, grade 3. And also, we also routinely will do a hormonal status, ER, PR, HER2, including Ki67, starting this year. And also, if it's in a biopsy, we'll also include lymphovascular permission. Is there any Is there any other specific type? Most of the breast cancer is non-specific type, but sometimes we could see a specific type, for example, lobular carcinoma, whether it's a mucinous carcinoma or mucinous component, micropapillary component, and other subtype. We also will include if there is any calcification in the report. Is there any ductal carcinoma in situ component? If there is any. But it's not fair for me to comment on this report because I don't see the slide, as I told you.
And I'm sure that you have noticed some of the reports came in without the immunohistochemistry, right?
Yeah,
and, How long do you usually need to actually process the IHC?
It depends again on the specimen that we receive, whether we receive it with slide. If it's a unstained slide, for example, already sent it in maybe 3 or 5 unstained slides, so immediately we could proceed with machine for ER/PR, HER2, and Ki67.
Yeah.
And usually, if there is no technical issue, the IHC will be ready the next working days lah.
Yeah, so the issue is that I think we do see a lot of patients came in with a diagnosis of invasive carcinoma, and yet we have a lot of all the question marks in our head, and I'm sure that Dr. Nina is asking like religiously for the IHC as well. And before we move on to Dr. Nina first, maybe I just ask Dr. Chiew, would you actually proceed for any ISH test, whether it's shish or fish in this patient?
In this patient, if it's a HER2 3+ strongly positive, according to a College of American Pathology guideline, it is not needed. Unless it's a 2+, and now you have the latest evidence to say we should also run the ISH HER2 for 1+ also. But I think the subsequent all this paper will slowly come later with more evidence. But at the moment, we don't encourage to do 3+ ISH reflex study. But for equal worker 2+, ISH HER2 is needed, but unfortunately, because of this financial problem, the patient have to pay out with ISH study. So it's not a reflex study as recommended by international guideline, like CAP guideline or UK guideline.
All right.
So actually, hi, Li-Ying, Dr. Chiew, can I ask a simple question? Dr. Chiew, you mentioned about Ki67. Do you recommend Ki67 assessment, and why is it mandatory, or why is it important for the whole diagnosis?
It depends. Thank you, Prof. Kartini, for the questions. Ki67, it seems like a topic, interest topic for some study, but in terms of pathological point of view, the Ki67 is not a mandatory, or is not a, we should put it as a gold standard practice according to the international guideline. It's good to have, but it's not a mandatory like a gold standard, a good standard of care like ER/PR HER2. ER/PR HER2 is a standard of care practice. Because the reason Ki67 is we had a lot of technical issue or standardization of reporting. Issue number 1 is the technical issue. Different lab have a different protocol, have a different incubation time. So the performance of Ki67 is not standardized.
Yeah, I think for this question, maybe Dr. Nina can answer more to this importance of Ki67, as well as maybe we step into the pillar 3 a little bit tonight and see what would be the best for this patient. I mean, based on whatever we have now. Dr. Nina, over to you.
I think Professor Benson has a question.
Yeah.
He's up his hand also. Maybe we can ask.
I actually didn't have a question. I was going to say about Ki67. In the US, we've backed away from using Ki67 because it can be a somewhat unreliable test. And difficult to measure. Our pathologist actually asked us to stop requiring it on a routine basis.
Exactly.
It's a dominant part of the Oncotype DX panel. And so for countries that don't have Oncotype DX, some have considered using Ki-67, but I don't think it's going to change your management strategy from what you've described so far. That was my addition. Thanks.
Thanks, Prof. So back to Dr. Nina. Any additional points would you like?
Thanks, Dr. Teo. I think, I entirely agree that it's not mandatory test for Ki-67. Sorry, can you hear us? So in our institution, we don't routinely have Oncotype DX, and it gives another window to understand the biology of the tumor. And for that reason, we want to understand a little bit more about the biology of the tumor, as well as sort of the luminal B tumors when the Ki-67 is very high. And for that reason, the Ki-67 helps us, together with the grading, to understand further about the biology of the tumor, and then in terms of aggressiveness of management of the tumor. But absolutely, it is not mandatory as per Dr. Chiew.
Can I also add a comment that, it's really nice to see that our hospitals, even Hospital Shah Alam does not have oncologists in the hospital, but they still produce the ER/PR/HER2 test routinely, which I think for a lot of us working like in PPUM, when we get referrals, some of these patients have been diagnosed in another hospital, and these results are not routine. So we waste time actually trying to get the blocks and having to do the test, because I think, Dr. Nina, you might want to comment that these biomarkers are almost like your holy grail now, right? You make decisions based on these. Maybe you want to comment on that.
No, absolutely. I mean, they the main pillar really for us to then think about how we manage the patient in the neoadjuvant setting. So for example, if the CT scan was not showing metastatic disease, then for a patient with HER2 positive disease with lymph node, axillary lymph node, then we were really thinking about neoadjuvant treatment approach versus if it was ER positive, HER2 negative tumor, then we could think about upfront surgery and then adjuvant treatment afterwards. So it changes the treatment paradigm completely to have this ER, PR, and HER2.
Yes.
Yeah, and it's quite interesting that I think the CT scan, the indication, because we don't routinely do CT scans, right, for the patients, especially if clinically we think it's an early breast cancer. And it's a good thing that I think Dr. C decided that this patient needed some form of neoadjuvant therapy because she's HER2 overexpressed and had wanted to refer to IAN, and they had this protocol. Is it, if you want to refer, you need a CT before they go for the scan, for the visit, right?
Yes.
So
clinically, for the mammogram, the lymph node is actually visualized there. So although the patient is clinically negative, but the mammogram shows that there is suspicious lymph nodes. Hence, I think that it's good that the patient did a CT scan.
Yes.
Okay. So I think in the interest of time, maybe we would like to just conclude with the last slides. I mean, we hope to actually get Prof. Kat to describe more on the lesions from the radiological imaging, but I assume that we don't have that much time now. So let's go through the timeline summary of this particular patient, and maybe the panelists could comment a little bit on the time frame of the journey of this patient so far. So Stephen?
Okay, so for the timeline summary for this patient, so when the patient was actually being diagnosed with a lesion during the public campaign, is on 21st of August. Then subsequently, she underwent the mammogram done in September 18, and actually was referred to us in our SOPD on 6th of October. And at the first visit itself, we actually did a biopsy for the patient. So on 13th of October, the HPE actually came back as an invasive breast carcinoma. And on 18, when we saw the patient, we break in the bad news to the patient, and we actually go through the mammogram. We actually notice that although clinically the patient is an early stage breast cancer, and the patient is a ER/PR negative for HER2 positive, we decided to refer to the IKN. So because the IKN require a CT-TAP, on 5th of November, the patient actually did a CT-TAP, and on 14th of November, we actually referred to the IKN as well. So IKN, given the appointment on 30th of November for the patient, subsequently due to some the CD unable to open, so a new date was actually given for the patient on 14th of December.
So there's a lot of logistics issue that happens in between all this time frame. So this is the things that we are looking at trying to minimize if possible in all the centers in the whole Malaysia. So from the time of diagnosis or the detection on 21st of August, it's definitely more than 60 days, am I right? Before the patient even got the first chemotherapy or any sort of treatment. So this is just a learning subject, but on and off, we do see these patients around in our center. So I think all this time frame can be cut short into a shorter time frame with the help of a proper team and also a proper framework that we are building up soon. So I think before I conclude this MDT, there are a few take-home messages that we have discussed through the MDT today. So first, I think besides the complete triple assessment, which includes the ultrasound in both the BRATS 0 dense breast as well as suspicious lesions. Okay, and also we mentioned about the biopsy, if possible, a one-off biopsy for both the palpable tumor as well as any other non-palpable lesions in detecting any multicentric cancer. And also we touched on the HPE report in which the IHC is very, very crucial nowadays, especially the ER/PR and the HER2. And we don't routinely send the H test for all the HER2 3+. And a CT scan may be indicated if there's a suspicion of probably a nodal involvement or any symptoms of metastasis. So I think we will hand over. Shall we just close this MDT for now? And we will leave the final few minutes for question and answer. Dr. Teh and myself will be handling the Q&A session, and the questions will be directed to the panelists here. So let's have a look at the chat box now. I think the first question came from Dr. Azlina, Miss Azlina. She mentioned as the patient was referred by an NGO, did the patient have to pay higher registration fees in Hospital Shah Alam? So I think this question goes to Stephen. Okay, all right.
Questions again?
Yeah, I think because it was referred from LPPKN, it's an NGO. So did the patient pay a higher registration fees in your hospital to see a surgeon?
No. As a patient, always for important, we charge the normal fee for a Malaysian, which is 5 ringgit to see our specialist hospital.
I think you sound a bit muffled, Stephen, but I can gather that you mentioned it's only 5 ringgit for registration for all government
for all
hospitals for a specialist clinic. Okay.
Yes.
All right.
Maybe I can add on to that, because sometimes we don't realize if the patient comes from a private hospital or private clinic, the patient will have to pay the full paying fee in Ministry of Health, and they will be charged full paying patient. Like first class patient. So be careful when you detect a cancer patient, especially a suspicious lesion, you want to refer and make sure they get treated in the Ministry of Health hospital. You may need to refer to the clinic kesihatan, to get a referral from a public clinic to the Ministry of Health so that they can get the fully subsidized fees, the bills from Ministry of Health. So one of the things that we're trying to do in Rebong is to help people, let's say GPs who are private sector doctors, they want to refer to MOH, but they realize if they refer, the patients will have to pay full paying fees. So what you can do is to refer to KK, but we want to empower KK, the Klinik Kesihatan, to be able to just give a cover letter so that these patients will be seen in our government hospital without having to be, you know, and you save the time of the community clinic doctors also by doing this. So obviously there are a lot of policies in our country that's not really helpful. You know, we can't really use private sector to help refer needy patients to the right place, like Ministry of Health. Yeah, so maybe from LPPKN, it's actually a government setup, so it's from the Ministry of Women's. So I think Shah Alam Hospital does take it like it's coming from the government sector. So that's why I think the patient was not paying full fees. I hope that answers the question.
So I can
Prof. Aishah, I know it, I think just reading through the messages, Dr. Teo, not everyone, even in our healthcare setting, is aware of this another hurdle that the patient actually have to go through when we're already working against the system. We want them to get seen as soon as possible, but this, you know, with this other extra paperwork, patient might then not get seen quicker, and they might not want to go to a KK and then to get seen. It just highlights the main issue that we have right now is policy change.
And I can sense all the frustration that even us are experiencing for our patients. So, you know, putting ourselves in their shoes is even worse. Okay. All right. Any other further questions? Because the other question posted by Dr. Fadhlina about two or more lesions, palpable and non-palpable, I think we have already discussed in part of our MBT discussion earlier.
Yeah.
Okay.
And then one more thing to highlight, yes, palpable, non-palpable. For us working in tertiary centers like UMMC, it may be we have a good relationship with our radiologists. Thanks, Prof. Kat, that we could actually request for the radiologist to actually fast track this ultrasound or mammogram guided biopsy, even for with patients with palpable and non-palpable lesion. But sometimes logistics and certain hospital, you may not have this facility. So I think Dr. Fadhlina mentioned that why did the patient have to go from multiple appointments? One is to biopsy and then get charged again for biopsy, then go for a second appointment for the radiologist to biopsy. Sometimes very overt kind of lesion, it is easier for us to biopsy bedside, and then if it's negative, or whether it will change a management, which may possibly change, at least with a positive confirmed biopsy of malignant, then they could fast track the ultrasound or the mammogram guided biopsy in another center. Is that what you're facing, Dr. C?
Yes. So usually when we want to request the load for the load of patients in the hospital, occasionally we're unable to do it on the same setting.
I think something wrong with your speaker, Stephen. Maybe you adjust a bit.
Can you hear me?
Just a bit muffled. I think something has been, something is covering your mic.
Okay. Okay, can you hear me so far?
Okay, maybe closer.
Okay, so all these are the challenges that we are facing, because for our radiology itself, we also are loaded with our patients. So occasionally we are unable to get the ultrasound to be done, or the mammogram to be done for the patient on the same setting. So there will be some delay that we are facing.
Yeah, and I don't think so. You have
like, you know, like, yeah, because you know, like, maybe I want to also mention that I think all of us need a lot of help, you know, because I think in PPUM we have breast care nurses, we have admin staff, we have people to help us organize our MDTs, send our list of patients' names to all the departments. So I think we mustn't discount that we need to have admin type of support to actually run any treatments, because our patients require multidisciplinary input, you know. So like, I think like even Dr. C, when we visited you in Shah Alam, you know, your nurses were actually running the counter. So I think it's a big challenge for all of you. And maybe, you know, as what Prof. Ben Anderson mentioned, maybe he could just come into the discussion. Patient navigation is actually an important part, and it's evidence-based, you know, and how we can organize ourselves better. We require a lot of political will, hospital management support so that they can support us, because I think clinicians are already very busy, and I think radiologists, they're like running all the services in the hospital, especially Shah Alam Hospital is like almost, is it secondary care? You call it secondary care, but you don't have subspecialties there. So you're doing everything. So it's like very difficult. So we need to, maybe like for us, we managed to get a resource center that was in 2005. And then we managed to get nurses to help us, additional nurses. From 1 breast cancer nurse, now we have about 3. And these nurses are very good. They are the ones who actually organize our MDTs, isn't it? I think Dr. Teo and Dr. Teh will agree, and Prof. Cat, right? That's how we try to get all this logistics, to get through. So I don't know, maybe Prof. Anderson, do you want to comment on what you're hearing from, is this common all over the world? I can imagine in most places in the world, especially in our setting where we are actually an upper middle income country, we have a lot of resource, we have the equipments, but we haven't sorted out our logistics to be patient-centered, I think if we think about the patient first, then we have to start thinking about how the systems would work for us, even for us clinicians to support us, and the radiologists, isn't it? So there are a lot of things that probably we need to sort out. And maybe Dr. Choong also can give some comments, because I think, Shah Alam Hospital is tough because they do everything. What would you think, Dr. Choong, would be a good way to move towards the future to help actually do more MDTs, and maybe to sort of help the logistics of getting the patient's appointments and all that?
Thank you, Prof. From this MDT meeting, we all have learned a lot regarding the ideal situation, how the patients should be managed, could be managed. I think moving forward, of course, we aim to have all these MDT meeting in our hospital, if possible, whenever the logistic allows. So just now, Dr. Stephen did mention something about the sound was a bit muffled, but I'm not sure whether the SOPD has the same limitation as my current department, whereby we are having a shortage of staff. We have, it's good to hear that at least the department has a nurse to handle all those, but in my department, we didn't really have a nurse for at least about a month. So what I find the main challenges for smaller hospital will be usually staff. But moving forward, I find the MDT is very useful. I previously trained under Prof. Cat, and the environment in the tertiary hospital, whereby there's enough support, it really makes a difference to the management of the patient. So we at Shah Alam also hope that we also hope that we can do more for the patient in terms of MDT, and also we will try to facilitate in terms of appointments for the patient.
I think maybe just a couple more questions, and then maybe Mei Sze, it's time for us to wrap up, right?
Yeah,
okay.
We need to wrap up.
So I think someone mentioned about standard report or tests required by IKN before acceptance, and is there anything that we need to highlight from the KK? I think in any...
can answer this. Stephen, do you want to answer?
It actually depends on types of the referrals. If for the cancer, for the breast cancer or the colorectal cancer, it's a different type of test that is needed. So for the IKN, usually after we refer, we have to send them an email, then they will reply to us through the email when they will give us the appointment. First thing. Second thing, they would, for all the cancer patients, they would like CT scan images done before sending the patients over. So these are some of the requirements for the IKN. And those unstable patients or the patient who is having infective causes ongoing, I don't think they can go to IKN at moments. So it still depends on the case basis.
Yeah, so maybe developing a system that is able to link all these referral centers both the hubs and the spokes are quite important. Like I think Dr. Nur Nadia has mentioned about the CT scans are unable to open and all. So maybe we develop a sort of like a central system. Okay, so I'll close this.
So I think just to reiterate, I think we should look at the WHO pillars, right? Because they also mention health information, the information systems that we have. How do we facilitate and make it easier for the patients, you know, so that we can share information, and all these in-betweens like CD, tak boleh buka, all these issues can be minimized further. So I am really looking forward to having, you know, more discussions. Maybe a little bit for Dr. Teo and Dr. Teh, because I think we should mention that this is only the first out of 6 MDTs that we will be having for the year 2023. So we have partners here. I think we have people from Pantai Hospital, Miss Pat, Mrs. Lina, and then we also have, I think, from Hospital Kajang, and IKN, HPJ, HUKM. So all these hospitals will be doing something like what we did today, and we will learn different things. So I hope that all of you would like to come and join us again for those events.
Okay, thank you, Prof. Aishah, and I will hand over this session back to the chairperson, Dr. Teh. Thank you.
Thank you. Thank you all to our panelists and our presenters and moderator for moderating this, conducting this session. It is truly an exciting first session for our program, and hopefully we could meet you again next year. We are aiming for a session every 2 months next year. With that, I hope these MDTs will improve overall breast cancer care and outcomes. And please bear with me for another few minutes. I would like to ask Dr. Suniza to share with us 2 slides on a GP course relating to breast cancer to improve timeliness. Dr. Suniza.
Assalamualaikum warahmatullahi wabarakatuh. Assalamualaikum warahmatullahi wabarakatuh, and very good afternoon. Sorry for the technical issues. Allow me to share my screen. I promise to just present about 2 minutes. Can you see my slides? All right. Thank you very much to Dr. Teh Mei Sze for giving me an opportunity to introduce this cancer care in primary care short course. So this is online learning especially for the general practitioner out there. And this course is endorsed by the Medical Malaysian Association, MMA, and also Academy of Family Medicine Physician, and as well as the Family Medicine Specialist Association. And this course is funded by and as well as MBPJ. As you can see here, as you know, late presentation and late detection, as have been presented earlier, is always a major issue in our country, and most of our patients presented late at stage 3 and 4, which affect the survival rates of our patient. And cancer treatment is becoming more complex, more complicated, and more expensive, and is also increased morbidity as results of the complexity of cancer treatment. So how are we going to tackle this issue? So one promising strategy to improve timely diagnosis is to train community-based general practitioners on how to detect cancers early, and as they are close to our community. So this development team of the cancer care in primary care short course is comprised of 30 professionals specialized in cancer. And there are 6 modules in this course, as you can see in the slides. And there's 2 virtual project Zoom meetings before and after the online course. The best thing of this course is basically you can work through the modules at your own pace, anytime, anywhere. So it just takes about 1.5 hours per module. And the best thing is this course is awarded about 20 CPD point. Is just nice to renew your APC for every year. So this course is very interactive and fun. It comprises reading materials, videos, and many case scenarios. And and through the scenarios, you will be able to manage a patient, know how to screen a patient, and manage different type of cancer as I listed in the screen, as you can see, and navigate effectively in a timely fashion. So there will also be a self-assessment quiz and many other activities in it. But you might wonder, how am I going to ask a question? Because it's online, right? So it is about the same like your Facebook, as like social platform or social media platform. You just write in the comment about the question or anything. Your admin and also the course coordinator will reply your any question accordingly. So by the end of the course, you should be able to recognize the signs and symptoms of these the most prevalent cancers in Malaysia, which is breast cancer, colorectal cancer, lung, cervical, and we would like to add on a prostate cancer for next year course. And you can see here from module 1 breast cancer, there is also sub-module in it, and it's very comprehensive, and you would be able to identify the diagnostic pathway, care pathway after detection of a symptom or abnormal cancer screen. And you would be able to recognize your roles as a healthcare professional in cancer care and identify the approach for provision of psychosocial support to cancer patient. And last but not least, to identify cancer support programs available in your community. We actually have done a pilot testing on this online program, and the vast majority of our participants would like to change their practice after this course. And we are going to embark another course in April 2023. So we hope to see you to join this course, and I would definitely encourage you to join this course. Apart of this, for the doctors, we also have Rebung training, the trainer community nursing for doctors out there. If you would like to participate, to encourage your nurses to participate this, you can contact our Dr. Chui Ping Ling, is our nurses lecturer from this address, chuipingling@um.edu.my. I think with that, I end my presentation with thank you.
Thank you, Dr. Suniza, for sharing with us such an extensive program, beneficial for the community and also to improve timeliness of cancer diagnosis. Is Dr. Ben still with us, or has he left? Because I think he has another meeting.
Yeah, unfortunately, we all read his comments in the chat box, so he has to go already. But I think he's quite happy that we are aligning ourselves to the WHO Global Breast Cancer Initiative. Oh, there he is, Prof. Anderson. Would you like to say something?
All I was going to say, I'm so sorry, I have another meeting I'm supposed to go to. I think your discussion was excellent. And I really admire how you're dissecting out the questions of what do we need to get, how do we do it in a timely fashion. What I was going to say is that when I started in breast surgery, the radiologist, we would order every test individually. And we came to a place where the radiologist consolidates their own workup. And we would send the patient and they would do the whole workup and they'd send it back based on guidelines. And I thought but the idea of you're working it through, we also would start to watch this on a monthly basis to make it a standard approach. But I really admire everything that you were doing. That's what I was going to say.
Thank you very much, Anderson.